So it is my pleasure. Thank you. So it's my pleasure today to introduce Dr. Corinna Löckenhoff. Dr. Löckenhoff is the Janet and Gordon Langton Professor of Psychology at Cornell University and a professor of gerontology in medicine at Weill Cornell Medical College. Dr. Löckenhoff is a fellow of the Gerontological Society of America and the Association for Psychological Science. She's received numerous awards for both her research that advances the fields of gerontology and psychology, and also for her role as an advisor and a teacher. Dr. Löckenhoff is the director of the Laboratory for Healthy Aging, where she leads her lab in research examining the role of time horizons, stressful life events, and social relationships across the lifespan to get a holistic view of everyday decision-making and its implications for lifelong health. Today, she will be talking to us about aging differences in decision-making, a conceptual framework. So please join me in welcoming Dr. Löckenhoff.
Thank you so much for having me. I'm excited to give this talk. I'm not quite ready to give this talk because it's a new talk, and I just realized a couple of days ago that I wouldn't be able to fly to my conference leisurely tomorrow, but instead I would have to leave today right after this talk. So I had to switch from talk preparation to conference preparation. I considered canceling, but then I decided, no, let's go ahead and give this talk in its current form and hopefully get some helpful feedback from the audience. So, aging and decision making. Why should we care about it? Well, obviously, the populations are aging across the world, and also the resources to take care of those aging populations are becoming more limited as fewer people are born in a lot of industrialized nations. Also, the decisions that older adults are facing often involve high stakes, such as medical decisions or how to distribute limited retirement income over the course of one's later life. And then, of course, the aging process is complex. There's many different moving parts. And so it's important to understand how all these different aspects influence the decisions we make across the lifespan. So when I was asked to give a talk for this motivated cognition section, I thought this would be an excellent opportunity to look back over the last quarter century that I've spent studying aging and decision making. This is how I looked like when I first got into this field. This is Halloween 2000 when I kind of came up with the focus of my dissertation research. Here I am today, still at it, and what can I say? Time flies when you're having fun. Of course, I couldn't have done all of this without my mentors. I started standing on the shoulders of giants with my dissertation advisors and my postdoc advisors. And since then, I had the joy of paving the way for my mentees. Here are some mentees become collaborators and some current mentees at the PhD level, and also the occasional undergraduate who ends up being a co-author. So here's the preview of the talk. Overall, over this time, I feel we have gone from the notion that is cognitive to the understanding that is complicated. And when I first worked on my dissertation, there were only a couple of summary chapters that were available on aging and judgment and decision making. They were both in books that were edited by Denise Park, and so they had a strong focus on aging. And when we looked at the paradigms that were used to study decision making and aging, there was a very strong focus on process tracing techniques. So there were these decision grids, and people were interested in how participants of different ages were looking through the information in those grids. Also, there were some studies in the realm of behavioral economics, such as temporal discounting or risk-taking, that were examining older adults, in addition to undergraduate students. But overall, there was a strong idea that cognition is what's driving age effects. In terms of which aspects of the decision process were studied, it was really about strategy selection and evaluation, and then implementation of decisions. There were some studies that looked at information search, but if they did so, they usually did so within the realm of what was given in the experimental scenario, and then how people utilized this information. And again, cognition was thought to considered as the main mechanism. And since then, the field has developed. So increasingly people were interested how people evaluated their decisions afterwards. Um, Also, there was increasing understanding that there's a step before information search, which is deciding whether you're going to engage with a decision in the first place or whether you're going to detour. And then with respect to the underlying mechanisms, there were more attempts to tease apart mechanics and deliberative aspects of cognition and pragmatics and experiential aspects of cognition. On the experiential side, there was an understanding of the affective processes and potential underlying mechanisms, including time, perspective, goals, and so on. On the cognitive mechanics side, there were efforts to tease apart components such as speed and memory. Also, there was more emphasis on the role of task characteristics. What types of tasks are we looking at? What is the outcome domain? Is it personally relevant? And also, what is the role of framing? And a lot of my early work was looking at positive or negative framing of decisions. So things were getting complicated. And in addition, of course, people were working on understanding the neurobiology of decision making and how it influenced these different components. And then there were people asking about what does this mean for decision making competence? So with respect to that, there has been rapid growth in the field. So this is just articles on aging and decision making in Scopus. The increase hasn't been quite as exponential as in other fields, but it has been noticeable. So that's a good sign, but there's lots more to do. By the 2000 teens, there was enough work to start to put together a book on aging and decision making. I had the opportunity to work with Tom Hess and Janelle Stroud to do that. The edited book came out in 2015, and there we differentiated between neurobiology, behavior, competence, and applied perspectives. So these broad areas. But when I was working with my grad students, I often felt myself explaining over and over again all the different subcomponents of decision making that you should be paying attention to when you're designing a task and looking at covariates. And so I came up with this model first in a lab setting, where I reminded them that when you're thinking about decision making, think about all the different aspects of the decision process. Think about where you go from after a decision to before a decision, right? So like sequential decision making. And then consider all the different age-related factors that may influence the decision process. Of course, cognition, but also affect and motivation. Consider the compensatory mechanisms. Among those, consider the neural basics. And then all of this, of course, is influencing the decision process. Also, we have to consider task characteristics, the outcome domains, personal relevance, task type, complexity, and framing. All of this is going to influence the way that age-related mechanisms are influencing our choices. And at the same time, we have to consider contextual factors, lab versus life, external support, joint decisions, cohorts, and culture. All of those play a role. And as we were preparing this scenario and framework for publication, some astute reviewers pointed out that we should also be considering ecological fit, right? So how does the mind, the environment, and the specific strategy fit together in order to then influence decision competence? So this was published in 2018. Our lab has been working with this since then, and I want to acknowledge some important limits. First of all, there's a focus on psychological and behavioral mechanisms as opposed to neurobiological. And there's others who are working actively on understanding those, such as the Scientific Research Network on Decision Neuroscience and Aging. Also, it focuses on normal and healthy aging. And of course, when you're talking about cognitive decline in the context of Alzheimer's and other dementias, then really cognition is the driving factor. And there are initiatives such as the Advancing Reliable Measurement in Cognitive Aging and Decision-Making Ability that are looking at that specifically. So how do we work with this meta-theoretical framework? It's a menu. You can't implement it all. It helps in situating theories relative to each other. So it's meta-theoretical. It's not testable as a theory by itself. It helps to situate research within the field. It helps to identify gaps within the field. It helps to map directions for expansion. And also, when you're designing an individual study, it helps you to select paradigms, stimuli, and covariates in order to make sure that you're not missing anything that would be an important moving part in understanding decision making. One thing that my lab noticed when you're really having this comprehensive view is that you're much more likely to end up with null hypotheses because you're going to have controlled for typical age effects and how people perceive certain scenarios. You're going to have included all the relevant covariates. And in fact, my recent graduate, Julia Nolte, was joking that her job talk was really at least 50% null results. And I would argue that null results are not a bad thing. I think they're a good thing because in some instances, it's just as useful to know that something does not vary by age as knowing that it varies by age. So for the remainder of this talk, I'm going to highlight how we have used this model in examining two broad areas of decision making. One of them is the tendency to, 1 second, sorry, something popping on my screen. Yeah. So one aspect is teasing apart differences in decision engagement. So this may include avoiding a decision before it has started, taking an easy out, or not engaging fully. And then another line of research I wanted to highlight is age differences in engaging with social partners in decision making, from advice seeking to joint decisions. So let's dive right in when it comes to decision delegation and avoidance. And one area that we were particularly interested in our lab was decision avoidance as a decision deferral. So some earlier studies had shown that when people are faced with scenarios such as this one, the decision grid, if you give them an additional option to not choose any of the options for the time being, older adults are more likely to choose that option. And some of this early work found also that age was unrelated to decision conflict, but the work used extreme age groups and it was also powered for medium effects. So the question was, can we find a little bit more about the underlying mechanisms if we do this more systematically and include additional covariates? So my grad student at the time, Julia Nolte, set out to do just that. She examined 4 different scenarios, 2 consumer choices about cars and houses, the other one about a physician and a healthcare plan. And the choices that people were making were happening in the decision grid, and the decision grid was purposely designed to be difficult. So there was not one obvious best choice. We were successful in that people avoided on average almost 2 of the 4 choices. And we replicated the prior age effect, showing that decision avoidance was, decision deferral in this case, was going up with age. So Julia was interested not just in replicating the effect, but she wanted to understand how cognition and emotion may interplay in those contexts and how that happens across the full decision process. And so also to understand how post-decision evaluation comes into this. And so what she did, she assessed baseline affect and subjective cognition. She assessed during the decision people's affective responses and their cognitive load, and then afterwards post-decisional affect. And here's what she found. Across 2 studies, there were, with respect to the baseline measurements, there were some minor effects indicating that people with better self-rated learning and better self-rated memory were less likely to defer choices. With respect to what we assessed during the decision, so when people had just started to review the scenario, there was some evidence that those with higher cognitive load were more likely to defer the choice. And in the second study that was better powered, we also saw that older adults were reporting higher cognitive load. But statistically controlling for cognitive load or statistically manipulating cognitive load or experimentally manipulating cognitive load did not address age effects. Finally, we looked at post-decisional affect, and we found that older adults in both studies reported better post-decisional affect, but there was an interaction such that the benefits of deferring a choice were associated with age. So in terms of how you feel after you say, oh, I'm not going to make the choice right now, older adults were more likely to feel better after such a choice. It was not quite consistent across different scenarios. It seemed to be a little bit stronger for the consumer than for the healthcare scenarios. This is something that we find in other settings as well. But overall, Julia's research seemed to indicate that what seems to be important in driving age differences and the tendency to defer decisions is the post-decisional effect. And so this is what I mean when I'm saying that our understanding has gone from it's cognitive to it's complicated. There are, of course, other ways of avoiding or not fully engaging with a choice. And one of them is to simply press the easy button. And this brings us to the phenomenon of default effects. And again, Julia was interested in that. So what she was using was a scenario where people were asked to consider renting a new apartment or selecting a vacation home. And they had the opportunity to add all kinds of amenities to this. A stereo system or all kinds of other features that they could add. And there were two conditions. There was an opt-out condition where all of the features were pre-selected and then people had to actively deselect if they didn't want them, or an opt-in condition where none of the features were selected. And if people wanted them, they had to actively select them. And so in the study, we successfully replicated the default effect in that people in the opt-out condition ended up with more amenities than people in the opt-in condition. So people are ready to go with the flow. Whatever is pre-selected, they're more likely to stick with it. And so here is the significant effect. But the difference between the opt-in and the opt-out condition did not vary by age. So here, it turns out, yeah, more evidence for the null hypothesis. This didn't change when we controlled for all kinds of covariates. And so it seems that the tendency to press the easy button, at least when it comes to going with default options, does not vary by age. We were also interested in how people engage with the decision process at the level of information search. So previous research had comprehensively shown that older people compared to younger people seek less information. But what we were interested in is whether they would actively avoid information. So we looked at not just information seeking, but information avoidance. And this is in collaboration with Julia Nolte again. And then a wonderful undergraduate student, Stephanie Deng, at the time was working with us. We created a number of consumer scenarios where people were asked which of two versions of a product they would buy. One of these products had added information that was potentially troubling. So in this example, it's a water bottle which has information about a global crisis that limits people's access to water, or have an alternative where this information is not provided. And there were other examples such as buying a desk with information about deforestation, going to a cafe with information about nutrition or not, going to the beach knowing about the potential for skin aging, and so on. And so what we found was consistently that with higher age, people were more likely to avoid the information and choose the option that did not have the information. It turned out that we did this research in parallel with a group around Ralf Hertwig in Berlin. They had also looked at deliberate information avoidance. And this was a study done in Germany, so it involved information such as, a Nazi past in the family or getting access to one's Stasi file. And here the same effect was found. So overall, we seem to have evidence that with higher age, people are more likely to avoid information. But it turns out that here the task characteristics and the context were really important. So when we gave people the choice, do you want the version with the information or the version without the information? There was a clear age-related tendency to go for the no information option. However, when we asked people the same question in a different way, asking them to use the slider scale, to indicate whether they trended more wanting the version with the information versus without the information, then older adults were more likely to just stay in the middle. It's not that they didn't respond, but they just moved the cursor a little bit. And so essentially they were avoiding the choice about avoiding information. We noticed in a different study that, again, that the way a question is asked matters a lot. This was in the COVID era. We were gathering data in the early summer of 2020, when people had good reason to turn away from the media because the information about the virus was just so dire. And so we were interested whether there were age differences in how people engaged with media coverage and information about COVID-19. And when we asked an online sample to what extent they actively avoided media, age was negatively associated with self-reported media avoidance. However, when we asked them about their media consumption in recent months, actually age was associated with a decline in media consumption relative to pre-pandemic. So these two effects were basically contradicting each other, and we triple checked to make sure that we didn't just miscode the questions. And so finally, we looked at behavior. So on the last page of the study, we were telling them on the final page, what you will see is information about COVID-related rates and various other information that's specific to your local area. And if you don't want this information, click those buttons here so you won't see it. And so it turns out that older adults were more likely to click buttons in order to not see COVID-related information specific to them. So here, the evidence is pretty clear that overall there's an age-related tendency to avoid, postpone decisions, actively avoid decision-related information, but the effect is highly task-dependent, and this really paves the way for potential interventions. So another area where I want to highlight some progress that my lab has made in terms of further building out the model is the role of social partners in decision-making. So the original framework referred to others with respect to decision delegation and joint decisions. But in recent years, my lab has adopted a broader view. In real life, decision-making doesn't happen in isolation, and others may be observers, advisors, active participants, and recipients of our choices. They may be part of the ambient environment, but they also contribute to every aspect of the decision process. So one aspect that my lab has studied is how we make decisions that affect others. So one line of research in this respect has been conducted by Yi Lu, and she was interested in the phenomenon of social discounting. So this phenomenon that as we become farther and farther away from a social partner, we are less and less generous towards them. So if we have to divide money between us and them, we become less generous. And some prior studies had found that there's a difference by age in social discounting. So here you see how much money people are willing to share with others at different social distances. And older adults are overall more willing to give others money, and their willingness to give others money decreases less steeply with increasing social distance. However, those initial studies only used extreme age groups. Also, they used small sample sizes, and they were conducted in Asian contexts. And so E was interested in repeating this and getting additional information of underlying mechanisms in a US setting. She used a task where she asked people to imagine that they had made a list of 100 people at various social distances, and then they were asked to divide money between themselves and various people on this list. So what did she find? She found, first of all, she didn't replicate the effect that age is associated with the total amount of money given across social distances. So in the US, there was no such effect. And then there was an age effect in social discounting. So older adults were less likely to show decreasing generosity to more distant others. But once she controlled for demographic factors, and in particular variations in income, that effect was no longer statistically significant, but instead just hovered just above the significance level. So here's some evidence that when you start to control for factors, for potential covariates. And if you're also starting to get large lifespan samples, then you're more likely to end up with null results and maybe have to revise some of your initial assessments. Another line of research that my lab has recently been conducting is spearheaded by my student Tess Wild. And she's interested in how we make decisions with others and how that affects various stages of the decision process. Particularly, she's interested in decision consultants and also how people manage information in joint decisions. Let's first look at decision consultants. So when we make a choice, quite often, one way we seek out new information is by talking to others, right? So we're thinking about buying a new car, and so we're talking about other people, talking with other people who've recently bought a new car. Or if we're making a medical decision, we're talking to people who have previously made that decision. So what Tess started out with, she gathered a general population sample and asked them to consider hypothetical choices about various consumer and healthcare domains. And they were asked to list who they would consult with and how many times they would consult with these people when making those choices. And what she found was a clear age effect. So age was associated with consulting with fewer people, also consulting with these people less frequently. And she also looked at different types of sources, right? So she considered spouses or romantic partners, other family members, friends or acquaintances, professional experts, or religious or spiritual advisors. And it turns out that older adults also consulted with fewer different sources, and we controlled for whether people had access to all these different sources, because of course there's variations in terms of, social integration, and the effects remained even after controlling for that. And they remained after controlling for a whole bunch of different factors. Tess didn't stop there, though, because of course these were hypothetical choices in a general population sample, and so she was interested whether that also applied to people who were actively making medical choices. And so in that context, she looked at a sample of people who were considering joint replacement. These were secondary analyses of data that had been collected earlier by a former student, now collaborator, Catherine Griffin. And so what they were looking at were people who were considering having knee replacement or hip replacement in the near future. And they listed the names of people they consulted about getting this. And again, we found that age, even within a relatively restricted sample, so age 40 and up, age was negatively associated with the tendency to reach out to others. The age effect remained significant when we controlled for a whole lot of different things. And regardless of age, people who reported better physical health were actually more likely to consult with others. So it turns out that when your health is already limited, then you are also less likely to seek out to others and gather more information. So this led Tess to consider how information is managed when it's just a couple of people. And specifically, she was interested in how people are managing medical information in conversations between a provider and a patient. There are actually guidelines available. The NIH has published strategies for preparing for a physician's appointment. People are encouraged to list concerns and medications, but in real life practice, things are much more messy, right? So they're not as structured. Various information is intermingled. People may be bringing stuff on a computer screen. They may be bringing printouts from the internet and so on and so on. And Tess was basically interested just what is the likelihood of people bringing additional information to their physician's appointments? And in some initial conversations with Mark Lax, one of the co-heads of geriatrics at Weill Cornell, there would seem to be the phenomenon that as patients get older, they're more likely to bring material with them. And so we decided to examine this in studies. Sorry, I didn't have time to actually put the data in there because I was so rushed in preparing this talk. But this is what we found. So we found that as people, older people were more likely to bring written material with them. And in terms of the background factors, people are also more likely to bring written material when they had more recent physician visits, so they were more frequent healthcare utilizers. And also they rated the importance of health information higher, but they felt that they had less of an understanding of their health conditions. So these controlling for these did not fully account for the age effect, but this highlights the fact that when it comes to managing medical information, older adults are more likely to bring additional material to the table. And the question is how to manage this in a situation where medical providers are often limited in how much time they can devote. And they may not have the time to read through all of this information and explain to patients where maybe they're not having a realistic understanding of their own situation. So this raises the question, is there something that we can do in terms of external support to ameliorate the situation? And I had the opportunity to work with a current grad student, Yusing Hao, who's advised by Sala Kalantari here at Cornell, to start to understand whether we can potentially use a chatbot to facilitate the communication between these two partners in making medical decisions. And this is complex work that's done with collaborators at Mayo Clinic, MIT, Langone Health, and also Einstein College of Medicine. So the core question here is this realization that when we're trying to have a conversation, when there's a conversation between the clinician and the patient, there's differences in terms of the knowledge base that they're working from. So physicians have obviously higher medical knowledge and know more about treatment options, but they don't know about the experiential knowledge and the personal preferences of the patient. The patient, of course, knows what their own preferences and concerns are, but at the same time, they're lacking information about specific treatment options and the exact research behind the condition that they're dealing with. And so the hope is that maybe we can use chatbots in order to facilitate this conversation and before a decision is made in this joint context, to kind of bring people up to the same level of understanding of the situation. It's important to note that people are already using chatbots extensively. I was recently surprised to find out that my 87-year-old mother is having long discussions with ChatGPT about how to manage her heart failure. That leaves me a little bit concerned, and it highlights the importance of doing active research to understand what's happening, and how we can support this in a controlled and secure setting. Some initial pilot work that we've been doing is in this area, so bringing the patients up to the level of understanding of the clinician. And so in this initial work, we have constructed a chatbot. It's called MedEduChat, and it is designed to support patients who have been diagnosed with prostate cancer, but who have not made the initial decision about treatment. And so the idea is that it helps them to get up their knowledge, to develop their knowledge about their condition in order to then make better choices. It is closed domain, so it knows about the patient, and it also is limited, the chatbot is limited to information that has been vetted by the team of treatment providers. It's semi-structured, so it gives people options to go through different aspects of the problem space. People can also ask independent questions, and it is patient-centered, so people can actually they can modulate the level of complexity that they would like to see in this language. We have some additional data from a very small pilot study where patient participants were having a conversation with this chatbot under close supervision. So there was an expert that was essentially supervising the conversation to make sure that there were no hallucinations, even with this closed system, and that any of the responses would be appropriate. And if there were concerning responses, they would be followed up. It's a very small study, but I think initial qualitative information points in the right direction. So the three clinicians involved here were saying that patient education helps patients become familiar with concepts and engage in complex discussions. If we deploy this, I can foresee we don't need to answer 100% of all patient inquiries, but maybe 30% of questions that the chatbot won't answer. And also, this offers valuable after-hours patient education support because now people can actually access the medical charts at all times of the day. And so potentially get scary lab tests and other things when the provider can provide them context. And so the chatbot can provide an immediate source of information at that point. Patients were saying they appreciated the fact that they were able to get clarification for complex concepts. They also noted that there was an emotional component to that. And so this is really that highlights, again, the fact that both affect and cognition are involved here. And so it may be important. This is important for medical providers to know, right? That certain words may cause emotional responses. And potentially we could use the chatbot protocol also to assess the level of emotionality that a patient has or particular areas that are scary for them. What's interesting is that at least one patient noted that the chatbot was like a gatekeeper for questions. It helped to ease the anxiety of waiting for answers, and it's good to know that a certain question isn't resolved yet. So there's a tendency when you are faced with a medical diagnosis to go to the internet and Google everything about it. And so what patients were saying was essentially, this allows me to kind of step back and say, maybe this is information that's not useful to explore at this point. So overall, these results are promising in terms of having the opportunity to limit this gap between the medical knowledge level that a patient has when they're going into the initial discussion about treatment with their providers. So it kind of brings them up to this level. But of course, it would be just as important to maybe find a way to get an assessment of where the patient is at in terms of what their preferences are and the emotional responses that they have to managing their condition. So I'm out of time, and I just briefly wanted to touch on what's next. So I just highlighted some ways in which my lab has been using this model in order to get a better understanding of decision engagement and avoidance across the lifespan, and a better appreciation of the social context in decision making for people of different ages. But there's, of course, more to do. So we hope to tease apart age differences in decision engagement, avoiding a decision before it has started, taking and easing out, not engaging fully, avoiding information. And the goal, of course, is to figure out when it happens, when it doesn't happen, and then how we can avoid information and decision avoidance when it really matters. So when it's important for people to actually be present and be fully engaged in the decision. Another area, of course, is further explore age differences in joint decisions and utilizations of external support. In particular, it's of interest what kind of individual and structural barriers are arising. Some people are socially isolated. Others may not want to reach out to others because they think they might be perceived as incompetent or a burden. And then, of course, if we're using external supports, there's a question of digital divide and tech literacy. More broadly in the field, what I'm hoping to see is a further exploration of neural substrates, right? So there's an understanding of dual process models, compensatory processes, and also there's increasing research on physiological responses. So recent years have brought increasing appreciation of age-related changes in vagal function. And of course, having a stress response during the decision process can also potentially precipitate age differences. And all of this research, of course, should be conducted with an eye to ecological fit, realizing that one intervention does not fit all. So overall, it's complicated, and if anything, things will become more complicated, but that's a good thing because it keeps me and my colleagues in the field busy and will pave the way for tailored interventions. If you want to keep up with where the field is going, the Gerontological Society of America has an interest group for that. It's spearheaded by Julia Nolte, along with Ryan Best and myself as co-conveners. If you can make it to the Gerontological Society of America conference this week, in spite of the air traffic issues, You can join us for a symposium that is organized by the group, and you can also join our interest group meeting. But even if you can't make it there, you can take advantage of it. There's a newsletter that you can subscribe to, even if you're not a GSA member. And then we also have organized several webinars in collaboration with other interest groups. For instance, we recently had one on aging, technology, and decision making. So with that, I would like to thank my co-authors, my collaborators, the various institutions that I'm part of course, always the Cornell Healthy Aging Lab, and all the funders who have supported this. And of course, thank you for inviting me to give this talk.
Thank you very much, Corinna Löckenhoff, for this highly engaging and informative talk. And as usual, we have time for questions. You can raise your hand directly, or you can also enter your questions into the chat, and we will read them out loud.
And let me get something to write. Don't want to miss out on that. I'd be particularly interested in any suggestions in terms of further building the model, right? So there are some areas where we should branch out and acknowledge developing research. How can we integrate that?
Questions from the audience, yeah? Colleen.
So I had a question on the decision consultants piece of it. So were you looking at who the consultants were also by age range? Just out of curiosity, who were the younger adults compared to the older adults asking for advice, and who were they parent? Because I assume sometimes people might want to talk to their parents, right, as a younger adult. Maybe they lean more towards partners as they get older. But I was just wondering if you had analyzed any of that, saw some patterns.
Yes, so we grouped them in different ways for the publication. Tess, do you want to respond? Because I see Tess is in the audience, so she can give you the nitty-gritty.
Yes, so we grouped them into information sources, close others who were like mostly family members and spouses, and then distant others who were like friends, neighbors, coworkers. So yeah, I think in the future we'll actually have people rate characteristics like features of the relationship instead of us kind of imposing the closeness groups. But the only real trend was that most people throughout the lifespan go to their spouse primarily for as their consultant, and then a lot of immediate family members as well, and definitely less utilization of the what we characterize information sources like professionals or spiritual advisors, like a lot less utilization of those members than we expected to see.
One thing that we also did in the study, because there's some questions in terms of when people are engaging with others, to what extent are you engaging with them? As you're engaging with them, are you trying to make as good of a decision as possible? Or also, are you also trying to modulate your emotional responses so you're maintaining a good relationship? And so the thinking was maybe older adults are kind of trying to keep a good relationship even at the expense of making a good decision. But actually what we found, the trend was there was a significant age effect and was in the direction that older adults were prioritizing decision quality over the maintaining a good relationship, which is kind of interesting to see. Okay, it looks like there's a question in the chat. Yes, so information avoidance. Older adults engage in more information avoidance than younger age groups, depending on the task. What do you think are the underlying factors? Motivational change, cognitive change. So I think emotion regulation is definitely a factor. So in the scenarios that we've been using, added information is potentially stressful, right? So whether it's COVID-19 or it's knowing that your desk was built with deforestation. So one could argue that there's a trade-off between regulating one's emotions and getting all the available information. And so that is certainly a factor. Another factor could be that if you're getting too much information, you may actually not be able to manage all of it. And so there's some modeling efforts that have been made to understand whether maybe when it comes to getting more and more and more information, at some point older adults are kind of stopping when added information may not lead necessarily to better choices. So that's a possibility. Okay, what role do time horizons play in the model? For example, do older adults' time horizons impact reduced value of exploration versus exploitation, which then impacts behavior, reduced info seeking, less social reaching, and so on? Yes, so I didn't put time horizons in there because I would think of time horizons as a factor that influences motivation in the broadest sense, right? And so on the one hand, it may influence may focus people more on the present moment and focus on regulating their emotions more, enjoying the moment, savoring the moment. Also, of course, and I see Alexandra Freund in the audience, there's variations in terms of whether people are pursuing goals that are focused on continued growth as opposed to maintaining the status quo or loss avoidance. There's variations in terms of and of course that varies in terms of how much lifespan you have ahead of you, but also it varies in terms of the resources that you have available at different points in the lifespan. So I would consider time horizons as something that affects motivational priorities in various ways. And our lab has been looking, we routinely include measures of time horizons. But we have been branching out beyond just looking at, as we get older, the time we have ahead of us is more limited, to looking at the concept of self-continuity. So how connected do we feel with our past selves and our future selves? And what are the implications of that for decision making, right? So if we feel like there's a pretty clear trend that as we get older, we feel more connected with both our past selves and our future selves. And so then does that have implications for how much our past experiences are influencing our present and the extent to which we are making decisions with our future selves in mind?
Wonderful. I know there's a question by Alexandra Freund.
Some reason I cannot raise my virtual hand, so I Zita. Thanks for the for this overview of your work. It was really nice compilation of what you've done over the past 25 years. Seriously, wow. Okay. Anyways, my question was about the quality of the decisions, because like searching for less information and maybe even delaying or not deciding might be a good strategy. And you mentioned now in the discussion that older adults prioritized decision quality over social relations, which makes me wonder whether the delaying making a decision or not looking for a lot of information might actually be related to better decisions, not only to more positive effect, but also to actual better decision quality.
Yes. And I think, well, first of all, when it comes to decision quality, it can be surprisingly difficult to actually quantify that in experimental settings. I mean, the extent of back and forth I had with reviewers in terms of how to, especially when it comes to those decision tracing mechanisms, to define whether something is a good decision or not, right? So should we be assessing people's own preferences for different aspects of the decision and then weigh them to calculate? So that is one aspect. So what is a good decision is really context dependent, right? And that's why we need the mind environment fit component. Of course, Rui Mata and his team about a decade back have done analyses that show that there's age-related decrements in information seeking are not necessarily a bad thing, and they may be essentially satisfying the decision process. There are, however, situations where not making a decision or going with the status quo can be problematic, right? And so there's evidence that people may not be engaging in retirement planning, they may not be enrolling in additional coverage for healthcare. And so in those situations, it would be important to overcome those barriers. So I'm totally with you in the sense that it's what constitutes a good decision is idiosyncratic, and disengaging from a decision can make a lot of sense, and also making decision with limited input from others can make a lot of sense. But it really depends on context. In fact, Tess is in her dissertation work, she's interested how decision making happens in caregivers networks, right? So she's studying the networks that surrounding caregiver care recipient diets, and she's interested in how the number of people involved in decisions can potentially make these decisions easier, but also more difficult. As I said, it's complicated, deliciously so, as a researcher. Kendra.
Yeah, I was just thinking not just about the social relation piece, but about the social roles that people play and how those social roles change across the lifespan. So specifically, you start out your relationship with your parents is that you are being taken care of by your parents, and then as you grow older, you become a caretaker. So it's a situation where your social role changes, and I'm just thinking about how that might have an impact on the way that you are making decisions changes as well. So this is kind of a half-formed idea, but it might be something to think about in terms of the environment in which you're making decisions. So anyway, that's just something I thought I'd bring up in the context of your model.
Yeah. In fact, I think Tess is very much aware of that when studying caregiving. And so Tess is specifically looking at dementia caregiving, where the person at the center of the care system has limited decision-making abilities. But it can also bring up questions about how to utilize remaining decision-making skills in people with mild cognitive impairment, right? And so there's my colleagues at Weil, led by Mark Lags, have been doing work on more systematic, and then of course the whole ARM kata that I referenced earlier have been trying to understand what is decision-making ability in the context of limited cognition, and can we, instead of saying like you know having a stepwise, you know, is decision competent versus is not competent, how can we understand in any given context whether a certain decision can still be made by that person? And is it possible to frame the decision in a way so that it makes sense for the person and they can make an informed choice even if they don't fully understand the contextual features?
Yeah. And can someone still make some decisions in certain contexts, but maybe not decisions in other contexts, so that they can maintain autonomy in some areas of their life, but maybe not in others?
Anyone who is working with caregivers is very much aware of that. And in fact, just last week, this is very poignant. I had a long discussion with my mother, who's a caretaker to my father, who is in mild to moderate cognitive impairment, about how to phrase choices and how to kind of provide context in a way that makes sense within his framework of understanding and still allows him to make decisions about, you know, medical treatments or other things. So it's that's why I'm so pleased that Tess is diving into this whole complex area in order to understand not just what kind of support networks are surrounding caregivers and care recipients, but how do decisions work in those networks.
Thank you.
Sebastian?
Yeah, thank you very much for this really nice overview. I was really surprised by your finding that the default effects do not really differ between age groups. I found this I wouldn't have expected that. I found it also quite striking that at the same time you find these age differences in the deferral. And I wondered how you see the connection there, because in a way you could think that these two aspects could also be correlated, or at least that's how I would have thought about them. Like deferral is, and I just wondered how you see these two patterns and whether you think deferral and this defaults are usually should be correlated, at least in some contexts.
Yeah, and in some instances, deferral is could be a version of default, right? So imagine like when it comes to choosing a car, right? And your current car is still running. And then, not choosing a car for the time being is, in a sense, you're just going with the current default, right? And so this is definitely an area where I hope that future students will aim to tease this apart further and to better understand when is this happening and can we potentially tweak it in situations where there's no question that making a decision at this point would actually be beneficial for the person, right? So not foregoing additional healthcare coverage that they could get at low cost relative to the potential coverage, and just being overwhelmed by the choice and not engaging with it. Or, of course, there's insurances like to give you promising entry level rates, and then they later switch it, and so it's beneficial to basically reassess every single year. And there's evidence that older adults are not doing that, right? And so how can we override that? Okay.
And I find it very interesting also because you're asking your framework, because there could be also connection with the fit to the task characteristics or in the environment, because if I understood your studies correctly, with the default, they were similar in complexity, or the two scenarios were relatively well matched. And there's some research with monetary gambles, for example, that often older adults prefer the sure thing, but simply because it's cognitively, informationally simpler to process, not because of a risk aversion. And so I just wonder whether that could be also interesting to study, whether it has to do more with the complexity, because in your studies it was, if I understood correctly, quite similar.
Yeah, so for the choice deferral, there was actually prior work by Chen and others that showed that if they compared a more difficult choice that required more trade-offs with less trade-offs, and they did not see any variations in terms of how people of different ages responded to those. So for our study, we decided, oh, if that's the case, we're just going to go with the more the scenario with more trade-offs, because that way for sure we're going to have enough that the rate of deferral is high enough that we can actually start to explain why how it varies by age. And so, but it's possible that in that same study, if you look at the paper, Julia was also exploring an intervention where people were asked to write a little bit about the different options there, in the hopes that this would reduce some of the cognitive complexity and help people to kind of work through some of it. And it did reduce cognitive load, but it actually did not make people less likely to defer. And so it's possible that we kind of dialed it up too much. And so that when choices like when there's more of an obvious right option available, then the deferral tendency goes away. So then that may mean that maybe when it comes to maybe choosing healthcare coverage, we just need to structure the options for healthcare coverage in a way that the decision doesn't quite seem so difficult and becomes more manageable. But we may still see age differences, but then at least like we could say, okay, we don't necessarily want to make the age differences go away, but instead we just want the older group that we care about right now to reduce their choice deferral tendency to a point where they're actually functional in that particular setting.
There's one last question by Jasmine Moon in the chat.
Yes. Regarding the study that found post-decisional affect was driving age differences in decision, does the affect felt before making a decision, anticipatory affect, also drive age differences? And so no, so we did not find any effects of baseline affect. There was a general tendency that people who had higher arousal in one study were less likely to defer, but there were no age differences. And then when we assessed the people's affect during the decision, we also asked them, how much do you anticipate regretting this decision once you made it? And that kind of trended exactly in the same way as other aspects of affective functioning. And so we kind of rolled it into those. But we have done recent work on regret regulation. This is work with Julia Nolte. And so there seems to be not so much differences in terms of how people regulate their current regret, but there seem to be differences in terms of how actively people regulate their future regret. So stay tuned for that one.
Wonderful. Thanks a lot for this very engaging discussion. Unfortunately, we're at the end of our time. Thank you, Dr. Löckenhoff, for presenting here today. Thank you for participating in our session today. Our next session is going to be on December 9 with Alan Costell, so we hope to see many of you there as well. We wish you all a pleasant full evening and hope to see you in our next session. Goodbye.
Thank you so much. Bye-bye.
Please say hi to Ryan Best when you see him.
Yes, I will. If everything goes well,